So
this evening, I have the honor to introduce two very, very special people. We know that FAS is filled with many wonderful people, and two of the gems of our community, of course, are Dr. Walter and Dr. Brenda. You know, they truly are talented individuals, each successful in their careers. Walter is the director of Pediatric Neurology at Mount Sinai Health System, and Brenda is the director of Pediatric Endocrinology at NYU. And when I think about both Brenda and Walter, you know, there's always a rabbinic saying that comes in mind. The Gemara says that whenever you see the greatness of Hashem, it also mentions his humility. That whenever there's a description of God's greatness, how lofty he is and how wondrous he is a description of his humility. And the definition of humility, says the Gemara, is the ability to interact with everyone, those in need, those who cannot necessarily fend for themselves. So you have on one hand God's loftiness, on the other hand you have God's humility and his ability to interact with those who are in need, and those who in a certain sense need help with their lives. And I really truly believe that this is what captures Brenda and Walter. They are obviously very advanced in their careers and in their life accomplishments, but yet somehow they've managed to remain down to earth, highly relatable individuals, people who do a lot of chesed with their expertise on their free time, helping out countless people I know from experience over the years. And they're people who are, on one hand, very, very talented, on the other hand, remain grounded and able to assist the common person and anyone who may be in need of assistance at any given moment. Of course, they also have a long-standing relationship with Fifth Avenue Synagogue. They got married in the sanctuary not too long ago. And Walter, of course, is an officer for many years. He's a former president and now currently the chairman of the board. And they have supported our community on so many different levels for so many years. And we're honored to have them part of our community. And we wish them only much health and happiness and success and nachas from the kids. And then please God, they should just have joy in their lives for many, many years to come. Now, we are going to ask Brenda to formally introduce Walter. And Brenda, you can only say nice things, though. Only nice things in your introduction of Walter. Of course, there's only, I'm sure, only nice things to say. But she will formally introduce her husband tonight.
So thank you, Rabbi Babich, and thank you, Rachel, for the invitation, and Jacob Gold, and everyone for joining. So it is truly my pleasure to introduce Dr. Walter Molofsky, who is Chief of Division Pediatric Neurology at Mount Sinai Medical Center. He will be speaking today on pediatric neurology in the time of COVID. Dr. Molofsky completed his undergraduate education at Cornell University, where he received a Bachelor of Science degree with honors in neurobiology and behavior. He then obtained his medical training at NYU School of Medicine. He then completed a pediatric residency at Columbia Presbyterian Medical Center and a neurology research residency fellowship at the Neurologic Institute at Columbia Presbyterian Medical Center. He is board certified in pediatrics and in neurology with special certification in child neurology. Dr. Molofsky, following completion of his training, went on to establish with his colleagues from Columbia the Pediatric Neurology Service at UMDNJ in New Jersey. There he helped develop the largest clinical training service in the state of New Jersey and trained multitude of pediatric neurologists. In 1996, Dr. Molofsky was recruited to join a group and to develop the Institute for Neurology and Neurosurgery, which was affiliated with Beth Israel Medical Center. And although one thinks that mergers and acquisitions occur only in the corporate world, in fact, the merger and acquisition between Beth Israel and Mount Sinai landed Dr. Molofsky right into the directorship of the Pediatric Neurology larger department at Mount Sinai Health System, and where he's associate professor of pediatrics and neurology at the Icahn School of Medicine at Mount Sinai. Under his leadership, the division grew impressively, and it has now become nationally ranked among the top departments of pediatric neurology in U.S. News and World Report. Dr. Molofsky's particular interest is in neurovascular disease, strokes, arterial venous malformations, neurobehavioral disorders of children, developmental delay, autism, seizures, neuromuscular disorders, and headaches. He has authored numerous papers on headache, neurovascular disease, and neurobehavioral disorders. Dr. Molofsky maintains an active clinical referral practice with offices up at Mount Sinai and Union Square, West Orange, New Jersey, and he enjoys caring for patients in the Williamsburg area as well through the ODA at Williamsburg. Dr. Molofsky has been a trustee and officer at the Fifth Avenue Synagogue for over 25 years. He is currently serving as chairman of the board. In addition to all of his accomplishments, it is his generosity of spirit, his kindness and compassion that has endeared him to all of us. It is my distinct pleasure to introduce my husband, Walter Molofsky, who will be speaking to us this evening on pediatric neurology in the era of COVID. Thank you all for joining. Thank you again, Rabbi Babich, for inviting us, and Rachel and everyone. Thank you.
You have to mute it. Good evening. You have to mute or turn it off. Good evening. It's my pleasure to speak to everyone tonight. I want to thank Rabbi Babich and Brenda, and I appreciate everybody coming tonight to listen. You have to turn it on. It's still getting. Tonight I wanted to talk about pediatric neurology in the age of COVID, and let's see if I can open up this slideshow here. There we go. What we're going to do this evening is talk a little bit about the evaluation of children with neurological issues and how the advent of telemedicine in particular has impacted on our care. One of the aspects regarding COVID, it is certainly a medical issue for children and for everyone in the United States and the world, and we'll be discussing that as well. In terms of caring for children, one of the things that have evolved over the last 6 months has been conversion to telemedicine. We've heard a little bit about it from other speakers in the past, and I just thought what I wanted to do is cover a variety of aspects of pediatric, please, Bob, neurology, and explain how we can evaluate these children with telemedicine. I then want to speak a little bit about medical aspects of COVID in children, and then discuss how we can go forward in terms of school, the Shul, and exercise and clinical activities of our children, and then give an update on vaccines. Now, in terms of pediatric consultations and telemedicine, I'm going to review a whole host of problems that we see in pediatric neurology. Going to discuss some prenatal and genetic problems that we see, neonatal seizures, developmental issues that come up in the first year of life, stroke, seizure disorders, headache, and some neurobehavioral disorders and tics. I just want to point out that I've arranged with Rabbi Babich to give the physicians on the call tonight CME credit through the Reitz Rabbinic College at Yeshiva University. Now, I just want to explain that telemedicine, which is that's what I'm going to focus on a little bit. That is, these clinical problems and how we deal with them in the world of telemedicine is not new. In fact, telemedicine, you could say, goes back over 150 years. The first words spoken over a telephone, as everybody recalls, was by Alexander Graham Bell, who said, "Mr. Watson, come here, I want you," which we could take as a consultation request for someone who needed some assistance. Of course, 150 years later, we're still doing the same thing. We get calls from parents on the telephone and on various telecommunication devices that are available. And what's happened is the technology has improved, but now it's a tool. We use it to really continue the types of care that we provide. That is, the complaints, problems we see are the same. The technology is a little bit more advanced. And here we have a 6-month-old baby who's calling me on the iPad, and you'd be surprised how young children can use these at quite a young age. And I'm consulting with this little boy. Of course, since he can't sit yet, his mother is giving him some assistance. And we're going to discuss a little bit about how we can actually go forward and do this. Now, telemedicine itself presents some issues and some opportunities. The issues that we deal with is one is technology. That is the different formats that are available. We have telephones, we have iPads, we have computer programs, we have electronic medical records, and there's a lot that's available to be used, but it then poses a problem for those families that if we're doing telemedicine, they have to have access to this technology. And that's one of the issues that we deal with on a daily basis. There are lots of families that really just aren't equipped or aren't able to access the advances in technology that we have available. But what's made this feasible, especially in the era of COVID, is the fact that the telemedicine consults, which we'll discuss, are now reimbursed. You know, as I said in the previous slide, we've been receiving phone calls for 150 years. The classic joke about, hello, doctor, my son, I have a headache. What should I do? Take 2 aspirin and call me in the morning. This has been around forever. But what's happened is now, with the increase in reimbursement, that hospitals, practices, and both inpatient and outpatient can now utilize the ability to take care of patients remotely and get reimbursed, which means it can be expanded and integrated into our practice. When that's not possible, it can be a challenge. Now, one of the advantages of telemedicine is that, in fact, you know, for someone who's been practicing for 40 years and sees patients every day, and now instead of having 100% of my practice in the office, I have about 75 or 80% of my practice over telemedicine, at least for the next few months, is how we can actually manage it. It's been quite remarkable in how we'll be able to provide care, and that's because of an important fact, and that is throughout the course of medicine and medicine training, as we teach medical students, as we teach our residents, it's the history that is really the fundamental aspect of making the diagnosis and caring for families and for children. That is, the history tells us what's wrong, it tells us how you're doing, and on TV, on these iPads and iPhones, in this era, people are comfortable actually talking with us on these devices, and in some ways, it's a direct experience. Just like I'm talking to you, we can have a mother or a patient on the phone, and we've segregated time, put time aside so that we can listen. And it's the listening, which has always been a feature of medicine, that continues to be important, that allows us to actually do telemedicine, because we can listen in person and we can listen on a video. And so that's why telemedicine can help us, can work. We also get the opportunity to see the families in their home environment, which can be quite interesting at times. But very often, especially with small children, and that's my focus tonight, come into the office, it's obviously it's an exam room or an office. They're nervous. It's very difficult to get them to do what they are able to do at home. So by observing them in their home environment, by bringing back the screen and having them run around the living room or the bedroom, we can actually do what we call an observed exam. We can do pretty much most of what we need to know, okay, by 2 things. One is history. So we ask the family, we ask the parents, can he talk? Can he walk? Does he use one arm or one leg more than the other? So all of these historical questions that we normally ask We can ask over telemedicine, and then we can observe some of them during the observed exam. We can ask the families to have the child run around, walk, to talk, and we can pretty completely get a reasonable exam. Now, there's a lot of things we can't do by telemedicine, and I'll mention that as we go forward. But generally speaking, we can take a good history, we can do an observed exam, and we can make diagnosis and treatment plans. Now, this conversation that I just meant was really was new patients. It's excellent for follow-ups. That is, we've seen you in the office, you know, I've seen you at your child at 6 months of age, and now it's 10 months of age for a follow-up visit. Or I've seen your 6-year-old with headaches, and we've made some evaluation and treatment suggestions, and then I want to know how you're doing. And it's really wonderful to be able to schedule a video visit, talk to the parents and the families, and see how the child's doing. They don't have to travel. They don't have to take off from work. They don't have to take off from school. You wish they would, but there is no school. But and they don't have to pay for parking and tolls. So it's really a big advantage in many ways. You do lose the interpersonal relationships. You do, you lose a lot of the hands-on, and in certain diagnostic problems that we'll talk about, it's a little bit more difficult. But it can be very, very useful. And I would say 80 to 90% of the time when I have a patient, either new or old, the telemedicine visit can be sufficient. Let me give you some examples. Not only am I'll talk a little bit about telemedicine and intersperse it with technology and also some of my own interests. But if we talk about going from the fetus to for example, the older child, in sequence, let's talk about some of the problems that we present. In the prenatally, we see children who may have genetic problems that have been discovered on genetic testing of the parent. We may see some structural problems on ultrasound. This is an example of a abnormal brain MRI of a fetus. And you may not know this, but it's a vein of Galen, which is an abnormal vein that is present in prematures. And just to give you an idea, this is a MRI of 3 months after birth, and you can see how accurate the images can be. Okay, now I'm not going to talk about MRIs particularly today, but I wanted to relate it to telemedicine. And how does that relate? Well, for one thing, we can transmit these scans all over the world. And very often we receive scans, prenatal ultrasounds of various types, from patients all over the world. We're able to examine them and evaluate them, and in some cases reassure the families. But in another case, in a case like this, where we know the child is going to be born with an abnormality that needs repair, we can plan. So we can receive the images, we can discuss it with our colleagues over the internet and on conferences by web or Zoom, and then we can make a plan. And in these cases, one of the main plans that we do is to have the mother be transported to our hospitals where we can provide expert care. And for this diagnosis in particular, there's another thing that comes up, and that is the use of the internet. We get families from all over the world, and they find out about the programs at various hospitals, including our own, on the internet. There are family blogs. Parents will say, oh, if you have this problem, you should come here. If you have this problem, you should go there. So it's another use of the internet and of telemedicine in one sense. As far as treatment is concerned of this particular type of problem, just to explain how advances in medicine have gone, this problem in certain circumstances was 100% fatal 30 years ago. Now it's like 90% of the children are normal, okay? And that's because of treatment that has been developed with intravascular endovascular treatment, where we put catheter in this abnormal blood vessel leading to an abnormal group of veins, and we inject crazy glue. This cannot be done over the telephone. But I just wanted to show that if you before and after picture, just to give you some idea of how technology has advanced. Okay, and 30 years ago, child with the previous problem would not be expected to survive the first year. Now most of them do, and it's been a privilege to be witnessing this. Now, the next area that I wanted to discuss in terms of telemedicine something that may not actually come to mind to you in the first place. Everyone's familiar with calling me on the telephone. Everyone's familiar with an iPhone or an iPad that we can use to sort of do FaceTime or to talk. This is a picture of a neonatal ICU. And I hope many of you, that you all haven't had to have your children be placed in one of these units, but they are absolutely technological marvels. And this is a typical setup where we have these bassinets with all the equipment you could possibly imagine, okay? And we are often, as neurologists, called in to see these children after birth. They may have one of those prenatal problems we just discussed. The parents may have had a difficult delivery and the child is depressed at birth, or more commonly, the child may be having a bleed or seizures, and we're asked to consult. Now, I work at Mount Sinai on the west side mostly. Our hospital has like 6 hospitals. What happens when I get a phone call at 2 o'clock in the afternoon when I'm sitting there with an office full of patients about a child who's just been born, and I want to go see this child? Well, we have call schedules, we have backup that have made this, that allow us to provide this care. But a recent development that's been spreading not only around the country and also at Mount Sinai is the use of neonatal telemedicine. So here's a situation where we get a baby that's depressed or has a medical problem that needs care, and we have these specialized units. Now, this is a very complex unit. First of all, it transmits an image of the baby. It transmits the consultant. We get on our iPhone readout of all of the vital signs of the patient, and we have two-way communication with the physicians and the nurses taking care of the patient, as well as the mother. And what this allows us to do is a remote consult. We can ask the doctor or the nurse to show me how the baby moves, to show the reflexes, to measure the head, all the things that we'd actually do in person, okay? We can do remotely with directed care, and we can direct the care, and we can do an initial consultation, rather quickly without having to travel over to outside hospitals. It's not a question of inconvenience. This allows physicians at major medical centers to provide care at remote hospitals around the country. So you can have major medical center, in Omaha, Nebraska, and they can take care of neonates throughout the state, okay? It doesn't have to be, 100th Street and 5th Avenue versus 59th and 10th. It can be hundreds and thousands of miles away. And this type of technology is not only being used in the neonatal unit, in fact, it's coming to the neonatal unit, but it's been used in stroke care in adults. It's been used in the emergency room for consultation, and we're also going to be using it on the floors to see patients. Another problem that we see that can be facilitated through telemedicine, believe it or not, are seizures. Now, seizures are the movements that people do when they have abnormal electrical activity in the brain, and they're diagnosed by their clinical features, but also by what's called an EEG, which records brain waves. And this is a child who's been set up to have these electrodes placed. It's pasted. This is not a surgical procedure. They're pasted on the head. And now we have the ability to do this at home. Okay, so we can have a technician come to the house, put the EEG on, and the patient can actually stay at home, and the unit is monitored live on a telemedicine program. If the patient has a seizure, the family can push a button and it's read immediately. And then the next day, this whole system can be taken off and we can analyze the EEG over a period of 24 hours. Okay, so we have the ability to do this remotely at home. We have the ability to monitor it remotely, and we have the ability to save the patient all of the difficulties of actually coming into the hospital. Now, this is also a subacute problem. If you have a first-time seizure and you're seizing, you can actually come to the emergency room. But this is for patients who need an ongoing evaluation. Okay, let me talk a little bit about seizures. How can we see patients in the office with seizures? It doesn't, not on the office, but by telemedicine. And the reason you can do this goes back to what I've said before. It's history, history, history. For those of us who see a lot of patients with various disorders, it's the knowledge of the syndrome. It's a knowledge of the difficulty that patients have that allows us to make a diagnosis. Since there are certain syndromes and paradigms of seizures and other medical problems, we can ask the questions about what's going on, and we can help make a diagnosis. Just for seizures, just to stop for a moment, this is seizures, as we said before, can be either secondary or primary. Now, secondary seizures are seizures that are caused by a new problem. So, meaning head trauma, or a bleed, or a fall, or meningitis, okay, or a stroke, something that, you know, you weren't born with the problem, it's sort of been acquired, encephalitis, those kinds of things. And when we care for those children, they're usually in the hospital because we have to care for the cause of the problem. And we do EEGs on these children in the hospital. But there are a host of primary seizure disorders that children are just born with. Now, nobody is just born with these things. And what's happened over the last 20 or 30 years is that many of these syndromes, which are well described clinically, therefore I can ask you questions on the phone and I can actually make a diagnosis, have genetic components. So children can have seizures not because they have a bleed, or not because they fell off their bike, or not because they have an infection and meningitis, but because they were born with genetic mutations which can affect the flow of sodium and potassium channels in the brain, and this can cause abnormal activity. And these seizure syndromes can exist from the day one to the teenage years. And they have certain characteristics. Neonatal seizures is a seizure in a newborn, but there's, remember, history. But there's no history of anything wrong with the child, except for one thing. His cousin had it, and his younger brother had it. So this can be a familial neonatal seizure in a normal kid, and thank God, they look like seizures, they are seizures, but they can go away. So once again, if you're seeing and treating this child with a seizure, you want to take a history of what didn't happen, right? It should be a normal background, and you want to see if you can find a family history. Then there's something called infantile myoclonus, which looks like a seizure. It's a little jerk, but the child is fine. And this is actually not a seizure, it's mostly a muscle jerk, and you can reassure the family that this too will go away. Unlike infantile spasms, which is a much more complex and difficult to control seizure, and it's associated with medical problems. Another problem that we see with seizures is febrile convulsions. Kids who are normal, but they only have a seizure when they have a high temperature, between 1 and 5 years of age. But they're normal, so the history is there, right? You got a normal child. Oh yeah, the temperature was 103 and he had this brief convulsion. Has he ever had it before? No. Could he have it again? Yes. But if it's only with seizures, with fever, then it's a febrile convulsion. Kids get a little bit older. Lennox-Gastaut is a complex medical problem I'm not going to discuss tonight, but Pediatric is very interesting, or absence seizures. This is a stare. Again, it's a set piece. The child is talking to you. I'll count. I'm going to count to 10 and I'll have a seizure somewhere in the middle. You'll see. 1, 2, 3, 4, 5, 6. It's not the kid who's staring out the window. It's the kid who pauses. And why do I say that? Because we get a lot of consults on the, patient comes in, referred, because they want to know if they're having seizures. Take a history. The child who is, you're talking to them and they're looking out the window is probably not having a seizure. The child who pauses has a seizure. So when we do this over the telephone or telemedicine, since we know the syndrome, we're asking the correct the questions, and we can make a diagnosis. And this is an EEG that's normal, and this is one where the child goes into a absence seizure where it has a characteristic EEG pattern. And these kids are usually between 5 and 10 years of age. You get a little bit older, there's a child who could be 8, 9, 10 years of age, wakes up in the morning and has some shaking, can't speak. He could have a benign Rolandic seizure, okay? Again, this is a great word to tell someone that they have a benign problem, which means it's not dangerous, is a wonderful thing. And although these do look like focal seizures, it's a syndrome. Again, it occurs in middle age of childhood and goes away at their bar mitzvah. So you can reassure the family, make a diagnosis, by history. So if they call us up and we ask them what happened, God willing, everything is fine, we can potentially make a diagnosis. And of course, we do an EEG, which can show certain abnormalities in the temporal lobe, but clinically, it's important. And then another syndrome that we see is in teenagers where they can have episodes of either drop attacks, fall to the ground, or shaking, or tremor. And this is another kind of seizure disorder that children young teenagers can develop, okay? And it can persist, but the diagnosis, again, made by history. So you can do a preliminary evaluation of some of these problems. If the child is normal at the moment, if the seizure happened, or if the child is seizing, it goes to the emergency room. But if the child is actually seizing, then it's not seizing, but you need to evaluate him. You got to know the story. If you know the story, you can help make a diagnosis. So now let's go through the first year of life. One of the things we see in the first year of life, one of the complaints we see is developmental delay. Children whose motor development or tone is not normal. They're not sitting properly, they're not rolling properly, they're not using their arms or their legs in a normal fashion. And this certainly is very frightening. Once again, genetics plays a big role in our diagnosis, but so does the exam, which can pose a problem. So we can ask the families to show us the child, but this is one of the situations where you're probably better off seeing a child in person as opposed to doing a visit, a telemedicine visit. However, there are two things that can help us make a diagnosis. One is the history. So this child is not doing well. Was he doing well from the get-go? Was there a problem with the pregnancy, the labor, the delivery, okay? Or was this a normal child who's now just a little bit slow in his development? Maybe it's a normal variation, maybe not. The history can help us as well as checking reflexes. Very simple test, look at that, no batteries. However, it's one of the most elegant and informative tests in neurology, and I'm sure everyone has had their knees banged. And why do we do that? Well, when we bang the knee, it sends a signal to the spinal cord, and then it goes back, and the leg moves. That's a very complex circuit. So if I bang the knee, okay, and the reflex is too high, that means that maybe there's a brain problem, and the reflex isn't dampened properly. If there's a low reflex, that is, you have one, but it's slow, it could be a muscle or a nerve problem. And if there's no reflex, sometimes it could be a spinal cord problem. So there are ways to make a diagnosis, okay, and to lead us toward a diagnosis based on the history and the exam. Now, we can't do reflexes over the telephone, but sometimes we can, in the sense that if they've been to their pediatrician who's referred them to us, we may have that information, and so we can move forward. The other thing that we want to look at, in addition to the history of the past, is how the head is growing. A very important point, and we can get these facts to us. We have the parents who can send us old records, and we can plot out the head circumference. This middle black line is the 50th percentile. The head grows nicely, right? Okay, what's interesting is that the child with a large head, it also grows the same way and does a small head. What you don't want to see is a head that's growing and then suddenly shoots up, or a head that stops growing, okay? So this is one of the tools we have that's very low tech. You can look at it over the telephone if you have the data that can help us. And if you have a child whose head is growing normally and the history is one that's normal, then we can begin to move toward a diagnosis or possibly reassurance. If it's not, then we have to do other studies. The other thing is that we talked a little bit about reflexes and how the child's motor exam works. One of the complaints that we get a lot is that the child, his motor development is not normal, but he's using one side, he's right-handed. The parents will come into my office at 8 or 9 months and very proudly tell me that the child is right-handed like daddy. And I'm going, because he's right-handed like daddy because there's the left side is weak, and he may have a prenatal stroke that wasn't ever evident before. but it's not evident clinically because he's been doing great. Look at this bright-eyed little boy. But as the motor system develops, you can see some handedness. He's right-handed and this hand is not being used. So again, since history is so important, we can even sometimes make these diagnoses by history, and then of course direct ourselves to imaging studies to see what's going on. Another problem that we get in the office that we're doing a lot of telemedicine on is headaches. Now, headaches are quite common in children, and just like seizures, there can be secondary headaches, which everybody worries about. Of course, you could have an abnormal blood vessel in the brain, you can have an infection, everyone worries about brain tumors. But thankfully, most children who have chronic headaches have what we call primary headache syndrome. That is, it's just a headache. It's easy for me to say, not so much for the child or the parent. But it's a primary headache syndrome in which there's no structural abnormality. And we diagnose that by history again. Okay, and there are clinical features of headache that we can get on the telephone and we can do on video. And those are: how often do you get the headache? Where does it hurt? How long does it last? Does anything cause the headache? Does anything make it go away? And most importantly, has anything else going on? Have you had any change in your physical activity, your behavior, or your vision? And if you get a good answer, like a negative answer from the family, that can be quite reassuring. Of course, it's very difficult to look at the eyes to see if the child has papilledema or increased pressure behind the eye. And that's something that we would like to do. But for a first visit, we can get a very good idea. We can historically eliminate, secondary headaches. We can characterize the primary headache syndrome and very often make a diagnosis. Just to speak for 1 second, I show you in the beginning about the neonatal telemedicine. They're actually, we can't do, there's two things I mentioned that we have trouble doing, on the telephone or on video or Zoom, and that's one is reflexes and the other is looking at the fundi. The doctor looks in the back of your eye. Why? Because the back of the eye, the retina has nerves that come out of the retina and go to the back of the head. And if those nerves are swollen because there's a mass or something behind the eye, it shows up on the retina. So we want to see that everything is normal. Well, what they're developing now, I don't have a picture of it, is binoculars. And you take the binoculars and you have the child look into or the patient look into the binoculars, okay? And you push a button and you get a picture of the retina, and that can be sent out to a reading station. It could be anywhere. And you have trained ophthalmologists who can look at the picture and then send you back a message saying that everything looked okay. So even that aspect, we don't have an automatic reflex hammer yet, but we do have, hopefully sometime down the road, an ability to look in the back of the eye. So this allows us to treat headaches. Most of the headaches we see that are primary are either tension headaches from too much school or now too little school, or migraine, which is a specific severe headache syndrome that most people are familiar with in adults, but about 8% of children also have migraine. For those who don't realize that children have migraine, I just want to point out that asthma, the frequency of migraine is more than asthma. And everybody knows someone has asthma. But would you believe it? The history of migraine in children is actually higher. It's good news and bad news. Bad news if you have the headache. Good news in that you don't have anything else going on and we can usually control it. Finally, in terms of problems that we see in pediatric neurology is what I call neurobehavioral disorders. This is a wide variety of disorders of behavior and function. They include tics, which are blinking, or brief movements, kids with ADHD or hyperactivity syndrome, children with impulse control disorders, and obsessive and compulsive disorders. And you might be saying, I thought you were a pediatric neurologist, not a psychiatrist. Well, you'd be surprised. We take, the problem is this overlap. So yes, we do see kids with tics, but the kids with tics have all these associated behavioral problems. They may have ADHD and they may have OCD. The child who has impulsivity may also have tics or be hyperactive, and there are and so we can treat you know, we can treat some of these disorders. And not only can we treat them, but you have to know the company they keep, because you don't want one treatment to interfere with the other problem. And there are ways to evaluate this using telemedicine. And those include rating history, first of all, what's going on. You know, oh yeah, he hasn't sit still, you know, ever since he was 4 years old, he's been hyperactive, he doesn't sit still, he's in class, he's looking out the window, he's not paying attention, he's not focusing. And so there are tools to sort of characterize these behaviors, okay? And let's just make a diagnosis. To tics, people send us videos now, and we're able to, when the patient calls up for the visit, we can look at a video and see what's going on. These behavioral problems are a little bit more difficult, and I'll just pass on those right now. Okay. All right. So that's an overview of pediatric neurology in the age of COVID, which is pediatric neurology impacted by telemedicine. Let me talk a little bit about COVID. As everyone knows, this has been running our lives for the last 6 months. So far, as everyone knows in the world, it's been about 23 million cases and 800,000 deaths. These are the most recent numbers I was able to pull. In the United States, we have about 5.5 million people, and about 175,000 people have passed away from this disorder. Now, let me go over some of the details about this overall, and then talk a little bit about children. As you know, anyone who's lived here in the city for the last 6 months or 5 months knows that we peaked. The cases peaked in April and May, and thankfully have subsided very much over the last few months, and the level has been improving, reducing itself, okay? And at this time, all the hospitals were overwhelmed, and we had all these reports about insufficient space, insufficient ventilators, insufficient PPE, but that has now subsided, especially in New York. Around the world, I think we see the reverse curve. I mean, around the United States, in some areas, California and Florida, it's almost gone the opposite way. And hopefully, at some point, they all too will have passed the hump and begin to see a decline. If you look at COVID in children, it's been a reverse curve. In April and May, they used to say, oh, kids don't get it. But what's happened is that the frequency and the incidence has gone up over the last 4 months. And you can see cases, this is per 100,000, there may have been 13 in April, and now we have over 500 cases per 100,000 children in the United States. And this is due to increased exposure and also time. Children were more sequestered initially, and now as they become more active, unfortunately the incidence has gone up, but it still has remained quite low. If you look at hospitalization, this is by age, this is cases by age over the last 5 months, especially in New York. This is from a New York thing. You can see most of the cases have been 65 to 75 years and above, but the middle-aged people have also been quite affected. Children, yes, but thankfully not so much. But the numbers are going up. There's been like a 95% increase in the last 2 months because of exposure. If you look at hospitalizations, it's the similar curve. You see most of the people hospitalized have been over 65. Okay, and this is due to the fact that when they got the disease, they have a lot higher incidence of comorbid infection and comorbid problems, and they're not able to handle the virus as well as younger people. Okay, unfortunately, this gives the teenagers and younger people the impression that they're immune, but they're not. Okay, and the preventative measures that we should follow really need to be followed by teenagers and children as well, and we'll talk about that in a minute. Okay, if you look at mortality by age, it again mimics the hospitalization rate. It's been mostly older patients above 65. to 75 with comorbid disease. A lot of these, if you look at that original number of 20, I think, where was it, in New York? I don't have it here, but in New York of 23,000 deaths, as you know, about 5,000 to 6,000 of them, maybe close to like 30 to 40% were from kids, from adults in nursing homes. And so there was a very rapid spread as these patients were initially brought back to nursing homes. And unfortunately, that contributed to the high death rate. And they were also older people, because that's who's in the nursing homes, and they had a lot of underlying mortality, underlying risk factors. And so that's why the mortality rates were so high. If you're interested about where you live, I don't have the Hamptons here, but I do have Manhattan and New York City. And you can see that there are areas of high case rate in the Bronx, in East New York, some places in Staten Island. We in the Upper East Side have lower rates, but it's not zero. Look at this, it's still 600, 65 per 100,000. So, and we all know friends and neighbors, unfortunately, who have gotten infected in our community. So all of the cautionary measures and the preventative measures that need to be done have to be taken by all of us. So let's talk a little bit about COVID in children. As I said before, you get increasing exposure has led increasing incidence, I guess that should read. And the incidence overall in children is about 8 per 100,000 now versus 164 per 100,000 in adults. There have been about 600 pediatric hospitalizations through July, okay? Much less than adults. The symptoms, however, are pretty much the same as adults, but are usually less severe, okay, with exceptions. Yeah. And they consist, as everyone knows, of cough, congestion, temperature, fatigue, anosmia, respiratory distress, and need for ventilation, very rarely in kids, and rash. What we have seen, however, is something called multisystemic inflammatory syndrome, which is a complex syndrome of inflammation that is almost an exaggerated inflammatory response in a small group of children, and it includes additional symptoms of ongoing temperature, abdominal pain, rash, vomiting, and most importantly, cardiac failure and shock. And these children require really comprehensive emergency care in a hospital. And there's no specific treatment, but it's symptomatic at a very high level. So this is what's happened to our children over the last 4 months. Those of us who they have 2 or 3-year-olds, it's very interesting. They think that it's normal for mommy to work at home. They're surprised that people have to go to work from 9 to 5. This has not been their experience. And if you want to explain this to children, and show them what you do, you can sort of buy them one of these play sets from Fisher-Price, which mimics what all of us have been up to over the last 5 months. Now, coming up in the fall, and now all over, is been this discussion about what to do about school. And this is a slide that begins to address some of the issues. This is what we call old school, where the desks are all grouped together, children are all learning in the same environment, and they're intermingling, okay? And this theoretically is new school, okay? Where the reduced numbers, separation, masks, and the hope is that since children in the initial, have low rates anyway, that this can be effective. Now, if you're gonna put kids in school or even Shul, right? There are certain rules that have to be followed to reduce the risk, okay? These are easily said, difficult in practice. For the buses, kids who are bused to school, you have to reduce the numbers on the bus. You have to mandate masks. They have to have separate the seating. There has to be entry screening at the doors to school. You want to keep out kids who have symptoms and fever, You want to mandate masks. As we saw on the last slide, you want to make sure that there's in-class spacing. If a kid gets sick, then you want to sort of create, if you can, cohorts where there's, you know, a group of 6 children who are mostly together in a larger area. And if one of them gets sick, then you have a restricted cohort that hopefully they've been in contact with, and you don't have to close down the whole school. But this is very hard to do. There has to be frequent cleaning, and there has to be adequate airflow. The airflow issue is very interesting. Airplanes, which are thought to be an enclosed environment that could be promote COVID, actually have very good airflow. And other than, you know, sitting next to somebody, with the normal, with all these other with masking and spacing and seating, the contagion rate is generally quite low. Here in the Shul, we've spent a lot of time and funds on improving the airflow in the main synagogue, the turnover rate and the exhaust rate, so that as we come to use the synagogue over the next few weeks, that we can do so with some confidence that we're reducing that risk. In school, lunches have to be staggered, and the desks, you know, or eat at the desk. Recess is difficult. You have, you know, try to tell, you know, 6 and 8-year-old children not to play tag and to run around. It's very difficult. And gym is a little more controlled because you can do exercises and things separated by space. But free play is quite limited. So these are the kinds of things that we have to do. Now, the big question comes up is, you know, should we open the schools? Should I send my kid to school? I don't have an easy answer for that. I think it depends on where you're located and what's the intrinsic, infection rate is in the area. I think it depends on how careful the school is in applying these rules. I know my children went back to school in Memphis, and my 12-year-old grandson came back and said, you know, Saba, this is ridiculous. Everybody's running around hugging and kissing, and, you know, and they're just not observing any of these rules. And he got very nervous about it. So its execution is always a problem. And it has to be enforced by the teachers and by the staff, and the rules have to be accepted. And if they are, then it's possible to move forward in this regard. Of course, with increased space and increased classes, it costs them more money. So that's another problem. Let me finish by talking a little bit about vaccines. The vaccine issue is one in which is in the news today. There are a lot of vaccines that are being, or mechanisms for vaccines that are being developed. Okay, we all heard about the vaccine in Russia that is actually being distributed to some extent. It really hasn't been finally studied in the way that we would like here in the United States, but that will be an ongoing process. Just to let you know what's going on is that it takes, the problem with vaccine development in the past has been it takes anywhere from 5 to 10 to many years to develop vaccines. The polio vaccine took almost 50 years, and the epidemic in the early 50s, it took about 5 years. The vaccine came out in 1955, and that was took about a 5-year window. Now, with different technology of vaccines and with a push toward going through the phase 1 and phase 2, the different trials, one is for safety and effectiveness, and then one is a phase 2 trial where they do it for more people, and a phase 3 for even more candidates to see how it induces immunity. Has become much faster, and the timeline is, it's now, this started in January, and now it's now coming on to September, and so for these 9 months, we're actually quite close to having some vaccines, and I would hopefully anticipate in the next 4 to 6 months that this will become a reality. Now, I just want to show that it's a good idea. Look what's happened to, when all these vaccines have been developed, this is what happened to the disease. The percentage decrease have been anywhere from, hold on, let me go back. Uh-oh. Let me see what we do here. Okay. I don't know what happened here. Let's see. Okay, so what's happened is you can eradicate these diseases. The hope is that if the virus stays stable, that the vaccines that are being developed now will be effective. There's lots of over 170 vaccine types that were being looked at. A number have gone through phase 1 and phase 2 trials. Phase 1 is to test in a small number of healthy people. Phase 2 is the larger group with higher risk of illness to see if it's effective. And then phase 3 is when it's tested in thousands and thousands of people to see what the effectiveness and side effect are. Just to speak a little bit about vaccines, I don't want to get too technical, but the coronavirus, it's a crown, has these spikes on the outside, okay? And what happens is that it attaches into the cell, okay? Proteins, RNA produces protein, the protein causes, the viral proteins are then assembled, it produces more vaccine, and the whole thing kind of cycles. Okay, the approach, the mechanisms for vaccines, the old vaccine technology was to take a vaccine, weaken it, and then inject it in the body and produce an immune response. Now they're much more sophisticated. They're using vectors to transmit either pieces of the DNA or RNA into the body, and that produces an immune response from T and B cells, and then hopefully that it raises antibodies, so that when you're sort of encountered the real virus, you will have antibodies that will prevent its replication. I showed you a funny slide before about the Russian virus, just to let you know that it's not completely out of the realm of possibility, because Israel is now I forget which hospital, but one of the hospitals. They're working on the vaccine, and anyway, the hope is that if not this vaccine, then other vaccines will become available in the next 4 to 6 months. Tonight, the president announced that convalescent serum from patients who've been exposed to the virus, that will now be available to help patients who are in the hospital and sick with the disease. You should know that the largest source of this immune this immune therapy and convalescent viral therapy is coming from the Orthodox neighborhoods in both Borough Park and in Lakewood. And if you read under the lines, underneath some of these stories, it's just really a blessing that the people living in these neighborhoods have really come forward to help people with this disorder. So, Baruch Hashem, soon we will be back in Shul. We will be able to travel to Jerusalem, and we will get back to our normal lives. And I just want to thank everyone for their attention. Thank you.
Okay, Dr. Molofsky, thank you very much for that very informative and interesting presentation. And thanks to Brenda for a wonderful introduction. Before we begin with questions related to your topic, I just want to say that I'm really so profoundly grateful for the assistance that you've provided in an advisory capacity as we reopen the Shul. We have relied very significantly on your expertise, and I wanted to make sure I acknowledge the important role you've played there, as well as the fundamental role that you play in the day-to-day operations of our Shul. And we're just so grateful to you and Brenda as pillars of the Shul, and of course to Brenda as Rabbi Roth's niece. We really consider her a member of the FAS royalty. So with that, this is the section of the program tonight where our audience has an opportunity to ask questions. And for anyone who has not participated before, you are welcome to submit questions through the Q&A function at the bottom of the screen, and then I'll be delighted to pass them on to Dr. Molofsky. So The first question, some questions have already come in, and the first question that came in is really a lifestyle question about how you ended up in this space as a pediatric neurologist.
Yeah, how I became a pediatric neurologist? Well, I was a neurology and neuroscience major in college. I was thinking about going into research, but my father made a very profound statement to me when I was in college. He said I could do whatever I want after I finished medical school. So I decided that I would go off to medical school. In medical school, I was fortunate to have been educated by, we had teachers there that were really amazing. We had Eric Kandel, who won the Nobel Prize in neuroscience. I got to work with Howard Rusk from the Rusk Institute, who took care of children with neurological disorders. And so I got a very early exposure to problems of children with neurologic disease. And then I was able to do some training as a medical student at Columbia, and was fortunate to work with some really pillars of pediatric neurology, which were my role models. And so basically I wanted to be like them. So that kind of guided me in my career.
Very nice. I have several questions related to COVID specifically. One of them is, when there is an at-risk child in the home, how do you see these families dealing with COVID? What extra precautions are they taking to make sure the child is not exposed?
Well, if the child has it, if the child has it, then he needs supportive care, to keep him, if he has any symptoms. You can usually, thankfully, since most of the symptoms are mild, they could be treated at home. But because they are potentially infectious, you have to, just like if it was an older person in the home, you would want to quarantine, the house and make sure that, they're not a source of spread. There are some studies that show that even though children have mild disease, they may harbor a very high load of virus. So it's possible that you can get it, grandpa, can get it, from his grandchild. So you want to be careful.
That was a question from the audience as to whether children can transmit COVID. Of course, there's a lot of information and misinformation floating around. So,
well, they cough to your knees, but it's, it's a problem. No, they can be transmitters. Yes.
Right. So in adults, we're seeing cases where there are lingering symptoms. People aren't fully recovering. They're experiencing things like chronic fatigue. Are you seeing this in kids? And do you see any long-term effect on children's neurology specifically?
In adults, the problems, have been some acute problems and some chronic problems. There's a higher incidence of stroke due to, intravascular inflammation. Okay, and then you can also have brain inflammation itself. There are, as you said, reports of this kind of what they call long haul patients who end up with chronic fatigue, they end up with headaches and cognitive impairment. Okay, the numbers it can happen in children, and I've had a number of patients in my office who've come in with these very non-specific complaints. In the past you would pass them off, as not being significant, but then when you find out that they've had an episode of, COVID infection, you have to wonder whether the child who comes in my office with chronic headaches, who never had them before, or chronic fatigue could be a problem. There's the incidence and the numbers will be less, but there's no reason to suspect it couldn't happen.
So, COVID, of course, was initially thought to be a lung issue, but we now know that it also has effects on the heart. And I'm curious to what extent it affects the brain.
Well, it's an inflammatory. The reason it affects all these organs is because of inflammation. Inflammation can affect, of course, the lungs to a great extent, because and it's most serious because it affects ventilation and respiration. But it can also affect the heart, and you can get inflammation in the brain. The most acute problem would be stroke or intracranial vascular abnormality, but diffuse encephalopathy, encephalitis, seizures have all been reported, indicating that there's an inflammatory response in the cortex of the brain itself. So, it's not the pulmonary problem gets the most press because, we needed ventilators, the patient couldn't breathe. But now, as we've increased the numbers, we see it affecting all organ systems, kidneys, lung, everything.
Right. Right. And how does a child who may already have a seizure disorder handle COVID? Does the COVID make it worse?
It depends on the source of the seizure problem, okay? We talked a little bit about febrile convulsions. So if you get COVID and you have a high fever and you're 3 years old or 2 years old, it could cause a seizure. There are some children, number two, there are some children with underlying seizure disorder. I spoke a little bit before about some of the genetic disorders of sodium and potassium channelopathies that kids can have. Even in normal circumstances, a lot of kids with those disorders, when they get sick, when they get the flu, when they get strep, when they get any illness, it lowers their seizure threshold without being a direct effect on the brain. And then, of course, the third possibility, of course, is that you can have a CNS complication from COVID directly. But anyone who has an ongoing seizure disorder, any illness, including infection, can lower the seizure threshold and can cause a seizure.
Mm-hmm. So one of the issues that all of us are dealing with, not just children, is of course stress and the toll that the pandemic has taken on our mental health. So I'm just curious how you see stress affecting children and families in your practice, but particularly children.
Well, we had this slide before of the little girl playing at the desk. All of us who have young children or grandchildren, are aware of the fact that initially everybody was strictly quarantined and now less so, but the opportunities for exercise, the opportunities for social interaction, the opportunities for play have all been restricted. And this is a big problem for children, young children. And this is, actually one of the reasons why, in addition to their ability to attend and focus, why there's a drive to sort of maybe to open schools, if it can be controlled, that there's not, in addition to an educational component, there is a psychosocial benefit from having children lead more normal lives. And as parents and as, people who have cared for people with, in our homes with COVID, like any chronic illness, it's very stressful. We've disrupted our travel, we've disrupted our work environment, we've disrupted our social environment, and this has been it's a significant stress. So we do see a lot of, in our practices, for those, you asked me before about seizures, but for the children who have some of these neurobehavioral disorders that I briefly discussed before, we've seen exacerbations of some of the mood disorders and some of the oppositional behavior, and as children try to deal with the restrictions that this has brought on.
Right. For children who are receiving ongoing care and services, maybe OT or PT or other types of care that they're receiving in clinic settings, do you see COVID impacting their ability to access their care?
Well, first of all, it's available online. Raise your hands, clap your hands, turn around. Many of my patients who have had early intervention, speech therapy, occupational therapy, physical therapy, are actually continuing to get it online. The question of access goes back to the primary thing that we discussed. And that's general access to the technology. People, and also it's the interpersonal thing, relationship of handling a child. The therapies are generally more effective in person. Try to tell a 3-year-old, to say the word la, la, la over again as you're doing the speech therapy. It can be very difficult.
Right. You touched on the fact that the COVID pandemic has restricted socialization opportunities, and I was just wondering if you could elaborate just a bit more on the impact of the lack of socialization. Obviously, it's difficult for all of us, but how much will this compromise kids who already may have challenges?
Well, hopefully it'll end. In the middle of it, it looks like this is going to be the new normal, but we don't want, God willing, this won't happen. But this is always, imagine it's difficult for those of us, who don't have these challenges. For the child who's autistic, for the child who has ADHD and can't sit still in the house, for the child that has speech and language problems and can't communicate, he's in a much more restricted environment without the resources that he would have available on the outside. So it's a bigger challenge for those children.
So a question has come in from one of our audience members about whether you and Brenda collaborate sometimes on medical issues.
Yes, we do. We have rules, though. The general rule is that we don't come home at the end of the day and talk about patients. In fact, Brenda has patients who I know or who are well known, and we both do, that we just don't discuss, and we try to make sure that we don't violate any privacy. And in fact, we do have an overlap there's an overlap of some of the medical problems, so we may ask each other some of those questions. But there's almost, I would say, a complete separation. There's a mechitza in talking about our own patients.
Right. Okay. Well, let me just add in that I have a very close friend who has children who are patients of Brenda's, and she raves nonstop about Brenda. So I always enjoy hearing.
That's good. I hear that in my office. You're married to Dr. Kohn? Wow.
One of your best credentials, right?
Makes my day.
Yeah, so nice. Well, it's so interesting to hear about what's going on from the front lines, particularly from somebody with your experience and expertise. And we're just so grateful for your time tonight. You and Brenda, of course, are a very powerful medical couple in New York City. We're so fortunate to have you in the Shul. And I just want to thank you again for the program tonight and for your commitment on a daily basis to the care of children and families in New York City and beyond. And with that, I'll turn it back over to the rabbi to close the program.
Thank you very much.
Walter, thank you so much for your time this evening and for everything that you do for our community. Just two questions I had for you before we officially conclude. And one is, do they have any understanding as to why young children seem biologically, from purely biological perspective, why young children seem to have a lesser reaction to the virus than someone who could be 25 and fully developed immune system, healthy? Why exactly do children, on biological perspective, have less of a reaction?
I mean, it's not clearly known. As I mentioned before, it seems that they can tolerate the viral load a little bit better, and it may be that their reactive immune response that's causing the complications that we see in the older adults is different than in adults. We do see almost everything we see in adults, we do see in children. And so it may be an exposure issue. If you look at the case reports, not so much the response, but the case reports in children have always been much lower. So they're receiving, the viral load and testing out positive is much less. And I only hope that, a vaccine and control methods will come along before the numbers increase in children.
Right. Well, thank you. And one last question you discussed a little bit with Rachel in terms of the long-term effects on a child's development. Being at home and not having people to socialize with and a lot of fear and stress in the environment. But you mentioned that even if they go back to school, for it to work and for them, the children not to place their families in danger by coming home, everyone has to follow a very strict protocol. So that itself, if it's really enforced by a school, could be very intimidating for a child. They're going to have to be very strong, the teachers and the administration. The kids are going to have to keep far apart from each other, not take the masks off. All that, I assume, could have a detrimental effect on the child's development as well, if it's truly enforced as it should be.
There's two ways to say it. Don't touch him. Don't stay away. Or you can say, okay, everybody take their spot by the circle. Okay, everybody, the circles are on the floor. Everyone sit in the circle. It's execution that can make this a positive, less of a negative experience and more of a positive experience for children. And it's just going to be another challenge for teachers. And if you ever walked into a classroom with excellent kindergarten, first or second grade teachers, one of the hallmarks that they have is how to manage 4, 5, and 6-year-old kids under normal circumstances. Many of those techniques can be applied to these circumstances. And I think if it's done in a positive way, then it can be managed, in the school. And hopefully this will pass. In terms of long-term effects on children, they'll bounce back. you know, as long as it's like everything else. If the attitude that the parents have and the people around them have, you know, if it's, oh, woe is me, whoa, 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 they won't thrive. If it's, okay, look, this is going on, this is what we have to do, and you take a more positive attitude, then the outcomes will be better.
Okay, thank you so much, Walter. And as you said, please God, this should all be academic in the near future, part of research, you know, journals, but not part of real life. And we want to thank you and Brenda for this evening and for everything you do for our community. And please God, may we continue to share happy occasions, semachot, for many, many years to come together as a family. Thank you for joining us. And thank you, Rachel, and thank you everyone for joining this evening. And everyone should have a successful, healthy, and wonderful week. Okay, bye-bye, everybody.